some kids just that make us think this is possible, and then we'll look at them together. And so this primarily been the case that I have been seeing. I trained here at Children's Hospital, my fellowship for allergy and immunology, and now I've been on staff for about 1.5 years. So I'm also relatively new to mastocytosis. Just you can see that I'm not practicing for that long yet. And other interest that I have is kids with eosinophilic disorders. So and I see kids with a lot of different types of allergies and immune problems in my clinics. All right.
This is just for recording. If you just speak into it like a normal mic, and just try to be careful not to touch up there. Just kind of hold it that way. You can record the session around.
And I'm sorry, I don't know about if everybody knew. They're only going to do 2 sessions instead of 3 because they're running behind. And
I bet you all the kids people are actually here next week.
Yeah.
Because none of the other sessions have anything to do with kids.
So why don't we
pass
or
do you want to? Is this going to be loud? My son is 7, and he was diagnosed with cutaneous without a skin biopsy at 4 months. And last year he had a lot of GI problems. They diagnosed him after about a month with systemic, and he also had really high eosinophils as well. So I hope this is my first trip here, and I've learned a ton, and I'm hoping to make another trip to come see you guys and get some more information.
6, and she's got a very weird form of cutaneous masto probably. She's got scarring alopecia and cough and flushing mostly, and some UP. And I'm a family doctor by trade, but I still know nothing about masto. Well, I've learned everything in the last 3 days. Now I'll probably be the regional consultant.
Turns 10 today. Okay. No embarrassment there, right? Cutaneous, we're from New Jersey, we'll say the Freehold area, and diagnosed about 2.5 years old, so doing quite well now.
Do you want to complete that story at all?
No, he did. Good job.
No, you're going to do it better.
I don't need anything.
So, Dr. Theoharides, I'm basically an internist and pharmacologist. I have been studying mast cells for 25 years, long before anybody told us about mastocytosis. I'm very interested in drugs or other approaches to addressing these problems. And we have an active lab in measuring various molecules in blood of patients, children or otherwise, that are not routinely measured in hospitals. And we think we have some associations that might lead to certain, at least new biomarkers and potentially new treatments in the next few years. We can only convince the powers to be to give a little more funding for this.
We need more doctors like Dr. Theo who think outside of the box.
Hi, we have 2 children, 2 out of 4 children with cutaneous mastocytosis. They both have solitary mastocytomas, and we're from New Jersey also.
Bonnie. I know you, Bonnie. Really? Kelly. Okay.
Oh, Kelly. From Huntington Beach, California. I have a little boy who is 2, and he was born with spots, and they told me they were birthmarks. And then as he got older, they start multiplying. And I took him back numerous times, and they said they were moles. So they finally took about 8 months old. I found a doctor who looked at it and said, "I think I know what it is," and scratched him, and they have flared up pretty quick. And so she diagnosed him, I think 8 months old, with the cutaneous masto. So he's got a lot of GI symptoms and flushing and stuff like that. So we're just taking it day by day.
This is my husband. We have a little guy that is 7.5, and at 2.5 we found out he had mastocytosis. We had spent a number of days in the emergency room with him going into anaphylactic shock, and nobody could tell us why. They just kept telling us, stop exposing him to what you're exposing him to. We saw a dermatologist one day and for ringworm, and the dermatologist asked what his spot was. We have one spot at that time, and sure enough, it was mastocytosis. He's only gotten one more spot since then, but we have a lot of breathing problems. So we're just kind of taking it day by day.
Anna just turned 4. She was diagnosed at 3 months. She's a pretty spotty little kid. And then in September, she was diagnosed with systemic. She has the major criteria and 3 of the minor. The 4th one wasn't tested for. But it's kind of it. We deal with GI symptoms and all the masto stuff. So.
Hi, I live in Temecula, California, Southern California too. It's 80 degrees. I just talked to my husband there. We have 3 kids. Evan, our oldest, he's here with me. He's 14. He, again, from a young age, he wasn't diagnosed but had the cutaneous, but also a lot of food allergies, again, showing up at ER with anaphylactic. But last year, it got so severe, he wasn't able to eat. He lost probably 30 pounds, was really sick, and so finally got diagnosed. Not that he's been technically by the WHO standards, but his sister also has cutaneous, and she, again, is exhibiting, she's 6, the food allergy, breaking out. And when she breaks out, it usually leaves her with a cytoma, after, when she gets like hives. And so we are just new to this whole group and learning, but last year I got on the neuroprotec from, Dr. Theo. We just happened to find it. We had a hard time finding gastrocrom. It was really expensive, but I would go and hand the script to a pharmacist, and they would hand it back to me and say, we won't order it. That was in Southern California. And so I thought, well, what do I do? Nobody would even order it for us, even if I offered to pay for it. And even the doctor prescribed it. We had a hard time finding a pharmacy that would give it. I had to actually call the distributor, say, who in Southern California has it? Well, in the meantime, I just looked up, well, what does it do? Inhibits IL-6. I don't know what IL-6 is, but I cross-referenced that, and it came up with quercetin in your paper. So I went, well, if they both do the same thing, let me try that. So he did that, and Evan had such a remarkable recovery. He gained 20 pounds in 1 month. He grew 2 inches, and he went from being extremely sick and depressed to looking vital and healthy. It was a remarkable recovery. I thought his gastro was going to click his heels on the way out of the door. He was so happy. So, subsequently he went on gastrocrom. That worked as well. We ended up finding it, but now he's been on neuroprotec, and he's been doing really well. He feels like he's had a little bit of regression, not a whole lot. Doesn't feel as good, but that's one reason why we're here, is to just see what else, we can do to help sustain him.
My name is Amy, and we have a 3-year-old. We from Western Maryland. We just moved there from Colorado because we wanted to get our son to a lower elevation and higher humidity, because we found that every time we went out of town, his skin stuff would resolve a little bit. This is not presenting like anything that we've seen. He's really presenting more like an adult with mast cell activation. He has some cutaneous symptoms like thickening of the skin in certain places where he would scratch to bleeding often, and eczema, but his reactions are all very systemic GI, a lot of hives, flushing, and lots of angry reactions to friction and heat and emotion. So it's like kind of classic for an adult, but we've been completely at a loss for finding somebody who could relate to it, because it's a rare disease with a rare manifestation. Very frustrating, but that's why we're here.
Hi, my name's you may have seen has the fire hat on. He's 2, and he has UP and systemic. We're originally from Canada, but we recently moved to Australia, so I could stay at home and be his main caregiver, because as probably many of you know, it's a bit tough to juggle everything all at once. So we're enjoying life in Australia, and our main challenge is stress, especially emotional stress. So you can imagine for a 2-year-old who doesn't talk very much, that's a big one, and that's what sends him into anaphylactic shock. So we're always trying to do a lot of things to keep his stress level down.
I'm from Toronto, Ontario in Canada, kind of outside of it, but I have 2 kids. My son is 20 months old, He was born with transient pustular melanosis, which is a really rare disorder, I guess, but it resolved itself within a matter of weeks. So when he was born, he was covered in spots, very different spots from UP. Instantly, we had problems with allergies through breast milk, and he was reacting and having hives all over his whole body, rashes, eczema, the whole works. So I actually didn't notice his spots right away because his skin was so inflamed with everything else. A resident through a dermatologist who had just studied mastocytosis by fluke happened to be in the office when we went in, saw the spot, they did a skin biopsy, and we found out he had urticaria pigmentosa. He would have been about 4 or 5 months old. In the past year, he's ended up having a lot of GI problems. He just recently had a colonoscopy, endoscopy, full skeletal x-rays, and ultrasound, and they were actually trying to rule out histiocytosis because they noticed different abnormal cells in his slides. Anyhow, long story short, it's brought us to now. He has severe food allergies, so coming here as I was hoping to meet people that have severe food allergies and masto and how they play off one another, because we do have a lot of problems with anaphylaxis. So including this week where we had 2 episodes back to back within 24 hours. And they're saying the one was from food allergies and the second one was more the masto, but the challenge from where I'm coming from is that a lot of people aren't familiar with it, even the specialists that we've seen, and we go to one of the top hospitals, we go to Toronto Sick Kids. So they've seen isolated cases of masto. They've of course seen a lot of food allergies, but no one has yet seen both of them together. So that's why I'm here, hoping that I can meet somebody else that's in this situation and how to deal with it and how the two play off each other.
My name is. I don't have a child with masto. I have mast cell activation disorder and multiple sclerosis. And I have a granddaughter that has autism. And I was interested in Dr. Theo's talk the other day and wanted to know if I could, learn any more about the correlation there.
Okay. Very good, very good. So thanks everybody for sharing. It's very, very interesting to hear, different perspectives.
We're going to have to leave in a couple of minutes. So
okay. Do you want to just start and ask
I think this is on everybody's mind probably, but if there's regression of disease, which they keep saying is going to happen at puberty, if there is regression of disease, does that mean your kid is done, there's no more protocols, things that used to bother them will not bother them anymore, drugs that they previously couldn't have, are they going to be able to have it? How do you know when the resolution is complete, and is there a complete resolution?
Yeah. It's a very good question.
Yeah. It's just recording.
So how old is your child?
I have a 7-year-old and a 9-year-old.
Okay.
So the 9-year-old seems to be growing out of it.
Yeah.
Yeah. So often, as skin symptoms improve, this is the other associated symptoms will gradually improve as well. Now, if all skin lesions have resolved most of the time, that will mean that associated symptoms have gone away as well. There are some patients where you may have some mast cells still somewhere else that you really don't see in the skin, and you can still have some symptoms. So there are really a lot of.
To follow the protocols for surgeries even after resolution of a spot.
I think so. If you have a lot of spots originally and they have all gone away. I think it really depends. I think when you look at the protocols for surgery, there are protocols that you use if you're high risk, and there are protocols that you use that associated if you have a lower risk. Let's say if you have I would treat a child differently and use a different regimen if you have severe widespread disease compared to if you have 1 or 2 lesions. Let's put it that way. And so if you only have 1 or 2 lesions left, I would probably choose maybe something that is still safe and use maybe some, for example, an antihistamine prior to the procedure still, rather than not doing anything. Eventually, though, these kids really eventually, if you really outgrow it, then you can come away from that too. But there's, that's the problem with such. There's no really exact timetable, because that's really that changes from one patient to the other. But I don't know if that answers your question at all.
And actually, I mean, there too have a solitary mastocytoma. I was going to.
Oh, there's solitary. Okay.
And I was reading. It seems to be more of a resolution with the solitary mastocytoma. Do you know of any that have come back later in life with a solitary mastocytoma, as some UP children have? Where it's just the mastocytoma completely gone away and then just comes back? I don't know of patients reported. I mean, I don't have. Since I see the kids, when they're kids, and I don't see adults, and I haven't really followed up on kids and what happens after 10 years. I really can't answer that question well, but when you look at the literature,
I would say
if it's gone, it's gone.
In the dermatology literature, that's really not reported. I mean, anything is possible, and certainly we've heard about this being a wide spectrum, and there might be a child who has a solitary mastocytoma but does have systemic mastocytosis elsewhere that, but it really is not reported that a solitary mastocytoma, or even a few, which still are in that category, resolve completely by the time a child's in puberty, and then later on recurs or becomes more aggressive. That's never been reported as far as I'm aware.
That's kind of that's why I asked you. I hadn't heard of any cases of solitary mastocytoma being a problem later on. Like you said, unless you had a systemic.
Right.
And again, solitary mastocytoma. I mean, we can tell you that this is probably the one version where we really see resolution in almost all cases, and there are a few patients where it stays until adulthood, but in these cases it really often doesn't cause that much associated problems too.
Right.
So.
Can you make a comment if I could?
Yeah.
I know this is going to be annoying. They're just recording it because then people may purchase the DVD.
That's right. I mean, I tend to agree. I would just like to say that in a couple of cases, not with solitary mastocytoma, but a few actually UPs, where things resolved in a child that I had seen when he was 3, and then nothing happened until he was about 9. He fell off a bike, and right where he hurt himself, new spots developed. Wow. So that doesn't mean to say it will happen with everybody, but it tends to be that if there is an irritation of the skin and someone has had the syndrome going, whatever you want to call it, the chances are that the muscles might get reactivated. So, do you stop someone from riding a bike? Of course not. But I would be, the dermatologists would be the ones to kind of give the advice. But, if a child has had the history, whether they do have UP now or the UP disappeared, if they're likely to go into some sort of an accident, skin accident, I will be more ready to take care of that site, whatever the appropriate approach to take care of that site is, rather than saying, it will heal by itself. You know what I'm saying? In other words, if there is irritation, I'd be more a proponent of putting a little steroid or putting something else, rather than just letting it heal by itself, because I've seen spots showing up at places that one would not have expected to.
Can I ask a tangent on if they outgrow it? Like I said, my son has diagnosed with cutaneous and systemic, and he is covered in spots head to toe. Mm-hmm. And with the systemic, he has the bone pain, the GI, the respiratory. So I don't know what else. Is there a chance that he could possibly outgrow it?
So the diagnosis of systemic mastocytosis, is this made just by the symptoms that he has presented with?
He had he had a bone marrow biopsy, and he had high mast cells and EOs. Mm-hmm. And they think the EOs came along for the ride because he was so inflamed. But he went on a feeding tube for a while, and we started from ground zero. And
the question is, can you still outgrow it even if you have systemic mastocytosis? Yeah. So there's certainly still a possibility. Kids with systemic mastocytosis, they may have a higher chance to have the adult type of mast cell disease where it actually stays with you. But it's really that's a very small percentage of patients. Since we don't look at bone marrows at all patients who present with symptoms, and overall we see so many cases get better or where it completely goes away. We still think that there are probably patients who have some bone marrow involvement initially, and it still goes away. So I think that's still a possibility. Yeah.
This is just a basic question, but sometimes it's helpful for us non-medical people just to understand in more layman terms. Yeah. We talk a lot about serum tryptase levels, and I'm sure any of us who've had our kids do it, we know our numbers, but I personally don't actually understand what that is and why it might go up or down. So I can quote you the numbers, but I don't really understand what that means in the context of what's going on in my child's body.
So when you know that these mast cells, when you have mast cells, they have a lot of what we call mediators. So they have a lot of substances in there that the body uses. So the mast cells have a certain function in the immune system to work against diseases, and some of these functions, the mast cells help with that, and they release certain mediators. And one of these is tryptase. So it's an enzyme that is released by the mast cells, and if that is released by the mast cells, it gets into the bloodstream, and you can measure it. Now, if you have a lot of mast cells, then and when the mast cells makes the tryptase, right? It makes the tryptase, and it basically stores them in little what we call granules. When the mast cells does this, a small amount of tryptase is also always released. A smaller amount before the tryptase is ready to be stored. A small amount is also released into the bloodstream. Okay. So there are two different types of tryptase. One is the ready-made tryptase that the cell has stored, and the other one is that slowly, always once you produce it, it gets in the bloodstream.
Is that A and B?
Yeah, and it's easier if you think about it in. I think it's easier to think about it in mature and immature tryptase. So mature is basically it's ready-made, it's in these little granules. And if there's reaction of some sort, the mast cell releases these. It opens up basically, and all these things that are in the granules get into the bloodstream. Right? That's usually the mature one. And the immature one is that gets constantly released while you're producing it. Okay. So it's hard because I can tell you already that a lot of physicians will not remember this. These details there. But what happens is if you have a lot of mast cells in your body, while the mast cells produce the tryptase, they will release a lot of it, and so you will be able to measure that. And you can measure that if also in kids who do not have mastocytosis, but they have an allergic reaction. When an allergic reactions, what happens is that the mast cells open up and they release all what they have in there. All right. So then you can measure it. They will have a higher number of the mature tryptase, right, because it's the one that's stored. Whereas in kids with mastocytosis, and you have a lot of you have more mast cells in the body, you will measure a lot of that immature tryptase, right? Or what you often distinguish, the total number of tryptase is generally elevated. But at the same time, if you have a reaction and you have mastocytosis, you will also release some of these that are stored. So the overall level might be high. But in the end, it is a measure. It often tells you how many mast cells you have in your body. It's kind of what we call when we talk about mast cell burden, right? How many mast cells have you? The tryptase is a pretty good parameter to look at, equivalent how many mast cells. It doesn't tell you where they are. So if you have a lot of mast cells in the skin because you have a lot of lesions, the tryptase can be relatively high. It doesn't tell you that you have necessarily the mast cells anywhere else. I don't know if that does it help. It's not that easy to.
Just a question about the tryptase.
Yeah.
Is there any evidence that any of the medications affect the tryptase level? Because I've asked a number of people, okay, if we're going to do our baseline tryptase to repeat, when we first did it, we were on nothing. Now we're on Singulair and Reactin and ketotifen. So how do I now interpret my tryptase level?
I personally don't know of studies that looked at if really these drugs change the tryptase level. If you
Because you would think if they're stopping mast cells from releasing, then
Right.
the tryptase level should be lower.
But again, when you're looking at baseline tryptase, baseline is is usually measured when you don't have a reaction, right? You're healthy, you have a normal check, and you check the level, right? So if the baseline levels in kids with mastocytosis, usually it's the immature one, right? That always gets released, and that shouldn't be really different. That shouldn't change if you're on drugs that even stabilize the mast cells, right? Because if you have mast cell stabilization, they will have less mediator release, but you still will have some production of tryptase, and it will still get into the bloodstream. So I wouldn't expect these to change much. Maybe Dr. Theoharides can comment on this.
3 comments. Number 1, in cutaneous mastocytosis, there has never been a study that I know at least where there was correlation of tryptase to the cutaneous mastocytosis, unlike systemic mastocytosis. So therefore, I know of children that have mastocytoma, 1, and yet they have very high tryptase, which wouldn't make sense from what we understand, and yet there are children that are covered with cutaneous mastocytosis have very little tryptase. So except that we use it as an additional index that someone yes has the disease, I've never considered it to be a prediction or predictive index of anything, to be honest. If someone all of a sudden had 2,000 something levels, obviously it must mean something pretty bad. But with levels between 10 and then 25 or whatever, I've never, at least from the colleagues that I know, considered it to be indicative of anything. That's number 1. Number 2, a paper was just published 2 months ago where they looked at tryptase levels in normal children. And they found out, I don't know if you've seen the study, that in children, normal children, entirely normal, 1 to about 1 year old, the tryptase levels were much higher, and that as the children actually became up to 3 years old, the tryptase levels fell. So one could have very confusing levels of tryptase in a child 1 year old just because the tryptase levels are higher for reasons that we don't understand. And I didn't know this until I saw this paper recently. The third point is that we clearly know, as my colleague indicated, that some tryptase is released all the time and some tryptase is released when things get excited. The first study was published by Dr. Swartz, actually, was in anaphylaxis, and I was the reviewer, now I can say so, when it was published in the New England Journal of Medicine. The highest level we ever see is an anaphylaxis, regardless of whether someone has mastocytosis or not. So keep that in mind, especially for the lady that was just describing, a child with masto and anaphylaxis, what have you. And finally, there's no question that triggers that we don't quite understand will trigger the mast cells to release, and it could be heat, it could be stress, it could be whatever. And when those mast cells release at that time, tryptase may not necessarily come out. So I wouldn't be surprised if one were to have a crisis of sorts, and it might be heat-related or stress-related, and tryptase might be the same or even normal, and yet the mast cells will be activated to release all kinds of things. Now, the final part, go ahead. Yeah, the final part is, can we actually follow any blocker of the mast cells, and would that make a difference? There have been some studies that steroids do actually stabilize the mast cells enough for tryptase to actually do go down and follow that it does go down, except that in children we shy away from using steroids for the obvious reasons, even though there are some steroids that are primarily active in the intestine, like budesonide, I won't go into details, that if a child, or an adult for that matter, has horrible GI problems, that nothing else catches them, then we might consider giving budesonide for some period of time because it doesn't get absorbed and it's not likely to dampen the progression and the growth of the child, etc. Then we talk about these stabilizers, whether it's ketotifen, which is very weak stabilizer, chromoline that seems to be decent stabilizer in certain people only, flavonoids that seem to be maybe better stabilizers. But no one has done a study, as you heard, to follow exactly the levels. And the reason why studies haven't been done, as we've been discussing all morning with other colleagues, is that there isn't a center where one can follow children that have fairly similar symptomatology. And as we heard just here, pretty much everybody I heard had different symptoms. So how do you do a study when they're so different? So we really have to kind of decide on children that might have only, let's say, mostly GI problems, or only mostly anaphylaxis, or mostly whatever, and then do a prospective study. And usually it doesn't take more than 10 children or so to do a prospective study, but someone has to do it, and there just isn't a place and money to actually do these studies, unfortunately. However, I'm always a proponent of getting at least a baseline blood, and if you were to send the baseline blood through your, whatever the primary or the physician is, for whatever studies he or she might want, save a little of the blood in your freezer box. Most of the studies that I've actually gone back to measure molecules, up to about a year, you might be able to keep the blood actually in the freezer box, and within a year things change and you can always measure it. And if you have to draw blood again, I would still save a little bit of blood. We usually save serum, so you spin the cells down and whatever is left at the top. Usually Quest laboratories are pretty good in measuring pretty much what we would ask them to measure, whether it's through a hospital or directly, but we still don't know exactly what to measure in many of these children. And we say we'll measure prostaglandins, or you might have heard PGF2 alpha. In some children it's high and some are not. I tend to like measuring 24-hour urine molecules. I know it's a pain in the neck for children to collect it, but what we say is with tryptase and certain molecules, the measurements in the blood are episodic. Something might happen, it goes up, and then a few hours later it's gone. With 24-hour urine, you're more likely to catch over 24 hours something might have happened. And we usually measure metabolites of histamine and prostaglandins and a few other things, and I'll be happy to go into it at some point. But there really isn't a very good index that you can kind of follow your child, to the best of my knowledge, all the time, unfortunately.
Can I just comment on this real quick? Thank you very much. That's a nice addition. So one thing again to know about when the tryptase, when we know it gets released in a case of of a trigger. If there's a trigger and you have a reaction similar to what happens if you have an allergy, the tryptase gets released. Really, you can measure it in the blood only for a very short time. And in some situations of some type of reactions, food reactions for example, it doesn't really come up that high anyway. So I think it is a good test for establishing a baseline tryptase, and for that I think it is actually a pretty good marker, compared to other things that we have. And there is though some correlation, I must say, if you follow tryptase levels over time, particularly if they have been relatively high. We're not talking about, let's say, 10 versus 12 or so, but if they have been now higher and they eventually go down, that usually correlates with the disease, the symptoms going away as well, and the general involvement being decreased. So there is, of the minimal markers that we have to test, I think it's still important one to use.
Not that I don't really want to take this. It's just more of a comment, I guess I'd say. It gets
It's really sensitive.
Thank you.
It's a little frustrating. The tryptase all the time. She was diagnosed, at 9 months, with bug bites, just bug bites. Then it was, you must use soap, something. She allergic to something. Okay, we had tryptase done, everything else done. Her stuff is all normal. She's 10, and her symptoms have gotten worse. She's cutaneous. So it gets very frustrating from a parental side, sitting here listening about measuring tryptase, or they're going to outgrow it when we're living it, and according to all the rules, we should be going from 4 to 3, she should be fine, It's not happening.
What do you mean 5, 4 to 3?
Her tryptase is
okay.
5 to, so we're way normal kind of thing in the thing. So it gets very frustrating because you're not taking it seriously, you don't get into, the doctor's appointments because you're not bad enough. So you're sitting here, it's just frustrating on his part.
That's a very good point.
I would say 2 comments on that. I think that's not uncommon, particularly when we've heard a couple people having frustration with a diagnosis initially, and
it's not uncommon with adults either.
As a pediatric dermatologist, most kids that I see referred to me are for moles or for a funny birthmark, or I've even had pediatricians pull me in and just say, can you just take a look at this because it looks totally fine, but we just want to tell the parents. And I'm like, that's urticaria pigmentosa. It's not totally fine. We need to have a little bit of a discussion. So I think there isn't enough information And that's part of what the society is trying to do in terms of getting the information out to the first line doctors, your pediatrician, your family doctor, to be able to even know about this. I mean, you have to know about it to even think about it and recognize it. So from a skin standpoint and recognition, I think that's not uncommon. The other thing that at least I have been taught is that, yes, we quote people that many children with cutaneous-only mastocytosis will resolve by puberty. But I think as we look at those numbers, that doesn't hold true in many cases. And some kids actually worsen. I've seen a few worsen around the time of puberty, probably because of hormonal effects.
My daughter definitely did that. Definitely.
Yeah.
And she definitely didn't outgrow it at all.
Right, and so it may be something that, again, that just needs more long-term study. That a good chunk of patients, pediatric patients, will improve, but some won't and will become more persistent cutaneous.
Thank you very much. One other thing is that when we talk about it correlates somewhat the tryptase levels, really we're talking about is there, it correlates to some extent with systemic disease, only, not that well. It certainly does not correlate with symptoms, okay? So not having elevated tryptase levels does not mean you're not going to have symptoms at all. And you should nobody should tell you that, or you shouldn't let anybody tell you this, just because you don't have elevated tryptase levels, the symptoms that you're experiencing on a day-to-day basis are not real. Okay, that's really not related, because you can have quite a lot of symptoms. And also, in a second thing, even if it does go away, it does not mean that it is easy to deal with. So that's. When you talk about benign disease, because there's an endpoint to it, and at some point it resolves, it can be quite hard to actually deal with it on a day-to-day basis. So just that you, yeah.
So what do you recommend then as a parent? Are we going to the doctor and but they don't really care because she's not bad enough. How do you deal with that frustration because you don't fit their criteria, or it's just you don't fit?
Can I say something? I didn't fit anybody's criteria either as a child. Being born with 2 spots, and now I have aggressive disease. You can say, you know what, not everybody grows out of it, and could you please listen to me and my concerns? And hopefully that will help get their attention a little bit, because not everybody grows out of it. Some kids will, some kids won't, some kids will never progress and will just have a few spots the rest of their lives. But others, it's a very slow progressing disease, and they will probably have an adult doctor by then. But it's important to just say, hey, not everybody grows out of it, please listen to me. And kind of go from there. You have to be your child's advocate and your own advocate. And as hard as it may sound, you kind of got to put your foot down and just say, please, please, please listen. And give them as much literature as possible.
I'm talking to doctors even that are the master specialists that still just don't get that same kind of response or respect because we don't fit the criteria.
I've heard how many times, is there a bone marrow? What is bone? Okay, it's great. Okay, you're going to subject the child to that? I don't think so. Okay, at least I don't believe in that. It's great to have some type of rules, okay, to try and put something, put it into a box. But you can't keep it in a box. Everyone in this room is different, okay? You guys are trying to get a disease that's, extremely large, and you're trying to fit in this little bitty space. It ain't going to work that way, folks, okay? It's great that you're trying. It's a first step, but be open-minded to everybody else, too.
Particularly when you look at the current classifications on the box, when we're talking about the boxes, they don't fit the kids well. Okay, just that you know and everybody who is all the experts will agree, right? So we don't have the right boxes for the kids.
You can switch now if you're interested. By the way, that's why I originally came in. Was to say switch. And you're right. The boxes do not fit the kids currently, and if those boxes were there and I was a child now, when 40 years down the road, I would not have fit any current box. So here's some emergency room passes for your parents if you want them. I'm just going to leave a pile here because some came and got them and some didn't, but I wanted to offer them to each of the groups. So how about it?
Just because we might be, going to other places, keep in mind that the triggers are very different. And some triggers, like we heard about stress, for instance, there's no question in most of the patients, not necessarily children, I found that stress is a trigger. And the stress Could be emotional stress, could be high fever, could be all kind of stressors. I'm not just saying psychological stress. So one question is, how do we address that? There are certain medications, they're a little better for that than not. For instance, we tend to give Zyrtec. But Zyrtec is actually the breakdown product of Atarax, which is hydroxyzine. And hydroxyzine is actually what we call anxiolytic as well. So it's an antihistamine, but it's also mild sedating. In Europe, it's very commonly used, for instance, to put ADHD children or children that had a very hard day to go to sleep at night. So if you were to choose something, of course you can give Zyrtec, but just keep Atarax in mind because it has an additional property for those children. And both. Morning and night. Yeah, morning and night. I'm not saying it's the drug to use, but it has a different action, if you wish, which in some families it might be important. I've also found, especially in adults, because I don't know enough about children, that a number of preservatives, let's call it that, in canned food and other food will make tremendous difference. For instance, monosodium glutamate will flush most of the, are the things like this in, for instance, there were 2 publications recently, I don't remember now, but if you just go to PubMed, you know PubMed, most of you, I guess, .gov, and you look for food, baby food, there were just 2 publications recently that most of the baby foods contain certain things that shouldn't be there. I'm not going to go into details now because this is not the time. But what does it mean that it shouldn't be there? It might be fine for me, but it certainly might not be fine for your child. So you just have to be a little more cognizant of even things that we consider sort of natural to use to children these days. And again, I'm not a pediatrician. I don't even have the right to go into it. All I do is read the papers and just kind of say, oh my God, maybe we should just be watchful of that. We just have to be very cognizant of what you already know. These children are very sensitive to more things than I would even imagine. So the more that you identify potential triggers and you remove them, the better it will be. As the other lady that was here that was talking about autism, a lot of children have gotten better, for instance, sufficiently better, but just removing certain things, whether it was gluten, whether it was lactose, whether it was whatever. Do we know what they do? We have no idea what they do, but by trial and error they figured out that it was helpful. And I think we will find, if you haven't already found, similar type of things in your children until such time as we know much better how to block these cells or what else to avoid. So I think you, to a large extent, would be the best advocate, and you already are for your children, but just identifying and telling us, he's stressed, and this is what happens. Well, let's figure out for your child how to avoid stress. Sometimes it might be when the children grow, homeschooling. Sometimes it might be something else. We just have to, until such time as, unfortunately, we know a little more.
Max isn't on any medications currently because every single medication that had any preservative, additive, sweetener, any of that he reacted to. And the only reason we could tell what he flared with right away was because he wasn't on anything. So the minute we gave him something new and his eczema would flare, or his hives would flare, or his flushing would flare. So we've completely eliminated gluten, dairy, soy, corn, all of the stuff that was histamine rich. And he literally, for the last 2 months, he's had a couple little hives. We have not had any really significant outbreaks, and that was going from over the summer when we moved, and I think that was part of the emotional, all of the stuff we had going on was emotionally flaring him, but it was also a change in environment. We had to strip all of our chemicals out of our house, out of our body products, out of our food. We adopted out our animals. All of those things made incremental changes, and now he's stable. But every little piece, Dr. Theo, every little piece made a really significant reaction with him, and it wasn't always easy to tell. Sometimes it would be diarrhea, and sometimes it would be skin, and sometimes so. They're so sensitive. It's just so challenging because I'm afraid to try any other medications now.
If I could just briefly, before you disappear, for what you mentioned, I just had a few questions, and there might be some thoughts there. So before you switch off to another room, just a couple of minutes.
had a question. My little one flushes really bad, and we end up in the ER. And every time we end up in the ER, even without medication, his heart rate is really high. He's fallen asleep in the ER, and his heart rate's over 170. But nobody can tell us why. And it's kind of this thing, like, you're afraid. Like, do I put him to sleep? What's going to happen? Because nobody can answer.
Let me just get a crack at this. Obviously, without knowing any child, no one of us would be able to say anything definitive.
We know, like, when he's not flushing, when nothing's happening, his heart rate is normal.
Right. But two things I wanted to say. One is, you, meaning our colleagues, would have to at least exclude other possibilities. I've seen children through colleagues, because I don't see children, that had another condition that is called pheochromocytoma, where actually, when mast cells are actually triggered, those cells are triggered, which are like cousins, if you wish, but in a different organ, but they release catecholamines that raise actually the blood pressure. We've also seen children that have spuriously hypertension rather than hypotension. Usually when histamine is released, it drops the blood pressure. That's very well known. In these children, there's a very well case that has been published actually out of Washington. This child had always hypertension, which is pretty much what you're saying, except that I don't know the blood pressure of your child.
His blood pressure is always normal. And that's what the nurses, when the doctors come in, they say, we don't understand, like, are the leads on him right? What's going on? Because his blood pressure is normal, his pulse is high, his oxygen will be back to normal. Like, he'll be kind of stabilized again, but his pulse just stays high.
It's not certain medicines that he has been treated with before.
We've asked if it could be the medication, but I mean, he's on certainly a lot. I think we're on like 27 medications. So my son has other medical issues besides mastocytosis. So I know we're certainly on a lot, but the doctors have all told us, like, his heart rate, nothing's related to the medication. So if we're in the ER and we haven't given him any medication, we just roll in through the doors, he's flushing really bad, he's complaining, and they haven't given him any medication, why would his heart rate be so high? And we've asked cardiology that, and they can't give us an answer.
Has he been seen by the cardiologist? That's the next thing.
Yeah.
You want like a 24-hour monitor, they also put on a monitor.
We did a bed monitor for a month.
All I would suggest, if they haven't done it at the time, is send a blood actually for total catecholamines, if they haven't done it. Because if the catecholamines are high, that would explain it, and it might be just a unique case. And if they are high, then we could give some of the known drugs to potentially block the effect of the catecholamines. So it cannot be put into a particular box, but you also need some answers as to what is high during that time that might explain it. So.
Also, if you think of what, when you're talking about blood pressure changes, that's something that you really see very rarely in kids, that the blood pressure actually goes down, right, like in adults. And you will much earlier, you will see the heart rate go up versus the blood pressure going down as a response of the body. Okay, if your blood vessels open up, and your body, first of all, is going to try to, instead of the blood pressure dropping, your heart is going to start pumping so that blood pressure doesn't drop, right, as a response to that. So much earlier, that's the first thing that the body does, and then you will see the blood pressure actually falling. And in children, they're very good at doing this, so that the real blood pressure changes you see, you often really don't see. So it could still be really related to the mediator release, I think. But you really want to rule out that there's not an additional problem there.
We're at Children's Hospital, but they just can't give up.
Where are you?
Yeah.
You were here.
We moved here to be with Dr. Costello.
Okay.
He is flushing. When
He
his heart rate
flushes.
when his heart rate is high, he is flushing.
He is the brightest red you've ever seen.
So isn't that like vasodilation? So
your
your heart rate would be up, so that your cardiac output is maintained, right? So yeah, so your blood pressure dropping is super late.
But his blood pressure is always like, when we go in, they
Right,
tell us
but that's
because your child's heart rate is maintaining his blood pressure with a higher heart rate, and that is great.
Yeah. It shows you how good it's my system is working there.
So his body is being effective. With your vasodilation, you don't have as much. You need more pumping through faster instead of, it's not tight anymore, so it needs more. So right?
Yeah, that's certainly correct. But again, you you want to really make sure. And I think at Children's Hospital, when you saw a cardiologist there, and you said that there's nothing else going on that would explain that.
Can't give us any answers. But when we asked, the mastocytosis doctor, she kind of said, "Well, I don't know. We just get a lot of I don't know."
Yeah.
We all do.
Yeah. So
Well, one, I wanted to know, is there any negative to long-term, like H1, H2 blockers, like Evan lives on Benadryl, that seems to be the thing that works the best for him? And then the other thing is there any kind of hormonal connection? He feels like he notices, I mean, obviously he got a lot worse in puberty. I know some kids get better. Like, is it connected? Because he feels like when his hormones, as any boy his age might know, is working really well, he feels like he feels really good. When he doesn't feel good, he feels like that's like not an issue, you know. So I'm glad he's not in the room so I can say this. But yeah, so those are my two questions. Just the long-term use. Is there anything like negative by him popping so much Benadryl?
Actually, not that I know of, but we always tend to give what we call drug holidays because the body gets used to them, and then you need to just up the concentration. Unfortunately, most of the antihistamines are fairly similar because in other medical conditions we can address a condition with a drug that doesn't belong to the same category, kind of thing. But to the extent that there are periods that one doesn't need as much, I would be a proponent of kind of either dropping it or even going off for a while and then coming back, or switching within reason. Don't go cold turkey. You know, you can kind of lower one and sort of add another one. But I don't know of any long-term effect.
Does hydroxyzine do the same thing?
Same thing as what?
As like Benadryl or...
It's better than any antihistamine I've ever used. The only downside is that it's more sedating. I'm sorry? Atarax. By the way, it's an old drug, so a lot of people, I don't mean us, don't actually use it because companies tend to actually, you know, whatever. It's a better antihistamine, pharmacologically wise, than any antihistamine out there. And it's actually better than Benadryl in my mind for the following reason. If you take Benadryl every day and you get sedated, you will continue to get sedated every day. 90% of the people that take Atarax, after about a week or two at the most, don't get sedated anymore. This little lady actually never gets sedated. Okay? The only difference is that Benadryl is over-the-counter and hydroxyzine still needs a prescription. Short of that, the American Academy of Pediatrics about 7 years ago had considered it actually as safe as Benadryl from a monograph that I remember.
The rebound effects are not supposed to be there, so a lot of parents have concerns about the next day. You know, performance at school, for instance, if you're giving this daily at night, is the school performance going to go down? Because, you know, that's been looked at in adults and work and, you know, their quality of life, et cetera. And it really has not been shown to be a risk in that sense, nor is it supposed to be addictive. I mean, certainly I agree that you need to titrate upward to get a dose response. So a lot of my kids, I use it a ton for kids with eczema. So a lot of my kids are on doses that would knock out big adults. But
in the kids' rooms, the kids are all done. They've had it. Okay.
The kids need to be done.
My son takes Atarax
or is it actually
for
Atarax?
We're switching that because
with children with Atarax for any history.
Atarax is more sedating. I mean, like he said, some patients don't have sedating effect. Technically, he's doing well with that routine. I don't think there's a reason to. But if he
it's actually pretty standardly used also in treating of allergies. That's the good thing. You know, mastocytosis is a rare disease. Allergies are common, right. So we have a lot of experience with giving these medicines for kids with allergies, and there are a lot of kids with allergies who need to take these medicines year-round with quite severe allergies, and that's one of the medicines where we really are not afraid of much long-term side effects.
He did the Atarax with the Zantac, but Atarax, because he has bad eczema too, so you're saying that might help, but you might need a higher dose.
Right.
Yeah, and you always have to.
It helps with the itch. It doesn't help primary eczema. I didn't mean to say that,
not really
but
eczema.
Okay.
Like, that's the other thing. I need to find out where do I get the topical, like cromolyn, because when I put that on there, it totally went away. So that's where no eczema medicines ever worked.
Okay.
But I mean, you have to work with your physician on it. But I always like to use like a long-acting one. Often combine it with a short-acting one like Atarax, like Zyrtec is basically a long-acting version of Atarax with some.
Actually, the action of Atarax is almost identical, 12 to 16 hours.
Yeah.
That's good to know.
I find
find that it wears off after 4 hours?
Yeah, they told me 4 hours, that it was longer.
Again, it depends what you use it for, but
Yeah.
the actual studies have shown it's long-acting. But not long-acting in the sense of a new drug that is long-acting. Clearly, if you take it, over time, it will wane. But they've reported benefit up to 12 hours, depending how much you give again. I mean, if you give a tiny dose, it's going to be gone in 4 hours, because basically you get a peak, and then it kind of starts waning off. So if you get a little bit, it's going to wane off very quickly. So that's why the answer is not as...
Is there a concern too about using Benadryl too frequently? Doesn't it affect the histamine? Like if you take it on a regular basis, like something about the histamine and like you'll get like the reverse effect.
No, usually if you have, there's some kids who respond completely, instead of making tired, they get really anxious. But usually if you have that, then that's your type of reaction. It's not that you change from one type to the other.
Right, so that's, in certain terms, you'll see it be called the paradoxical response, and that can occur with either Benadryl or Atarax, or any of them. And so some kids can tolerate one and not the other, or some kids tolerate none of them because of that. But that, in my experience at least, is something that occurs, pretty much right away. You find out the kid can't tolerate it. It's not like if you take Benadryl for 5 years, your risk of that happening goes up.
I usually use Benadryl as one of our first step emergencies. Would hydroxyzine work for that? Like if it was, if there was a flare, because Max's first is like hives and flushing. To any given trigger is hydroxyzine. It's fast reacting.
We have 5 more minutes. I have a comment to your second question later.
Okay.
I'll tell you. And I'll talk to you later. I can completely relate. My daughter's got 4.3 tryptase. She's 18 now. She had her first spots at 3.5. She is clearly not outgrowing it. She's got a lot of other things going on. And so low tryptase and not outgrowing it at all. So I'll talk. Yeah.
Doctors always say,
You know what? When we do we have a booth. TMS has a booth at some of the medical conferences, and it's funny. A lot of doctors come over and I thought they all outgrow it, and that's when I jump in. And one year my daughter was there, and they could see that she had them, and she was clearly not a child anymore. So, doing the TMS booth at those conferences, that's something that we try to. When we're at the pediatric one, we try to. If they make that comment, we, throw the thoughts out there.
No, go ahead. And then I have, after one thing I wanted to comment on allergies, because I have I've heard that now a lot of times, and I think that's something. Well, why don't you ask your question?
Mine was kind of a tangent, what we were just discussing. When you talk about taking a break from the meds, my son's been on the H1, H2, gastrochrome and all that for a year now. Is it time to take a break? And how long do you take a break for? And is it something I can wean him off of? And then if he has another episode, or is it something I want to continue doing?
If he's doing fine, I wouldn't do anything, to be honest.
But has he had any episodes? Or, I think that depends, because we see some children who go literally 6 months without having a single thing happen. And I think in those kids, I think it's time to see what you can take away.
Yeah.
But if he's still having a weekly or even a frequent flare, then I would keep things...
Not in the GI. He still gets some bone pain, and then the heat and cold affect him.
Triggers.
Yes. Yeah. So but I hate to keep you on, will he kind of become immune to it?
I would agree. If there are symptoms, you want to keep them on. The only thing you might consider doing, as I said, is maybe switching to another antihistamine, even though they're about the same. All I would add, for instance, I've seen and spoken to both children, the families of children and patients, they have, for instance, eosinophilic gastroenteritis or eosinophilic esophagitis. Well, in Europe, for instance, there is a drug called rupatadine, which is a very good antihistamine and anti-eosinophilic. So if there is that, and one hasn't tried a drug that covers the eosinophils, might be worth trying to get, 2 birds with 1 stone, switch to a good antihistamine, have a little added action to something else. But that's what I would do if there are ongoing episodes.
I want to say something to mastocytosis and allergies, food allergies. Something really that we hear now more and more about, but it's really not well described at all in the literature. So really, when you talk to doctors, they will not have much information to go, to read about, and so what they can base it on, what they tell you about this. So one thing is, you can have reactions that really are much more severe than what you would expect by looking at the degree of allergies that your child has. So let's say you see an allergist, they do some blood testing, for example, and they'll look at the levels, right, and they'll tell you, well, it's relatively low. It can really, you can have quite severe reactions if you have mastocytosis.
Because it can be non-IgE, right?
Well, it can be non-IgE, but also if it is IgE, which is the classic allergy, mast cells, they can actually bind up some of the IgE, and so it's often that you will actually see the total IgE levels being relatively low, right?
Sorry, what do you mean by binding up the?
So they can, mast cells, the IgE sticks to mast cells.
Okay.
All right, and the IgE is what you measure when you measure allergies, right? So the overall levels of the IgE, if you measure all the IgE in the body, if you have a kid with a lot of allergies, it's usually very high. If you have, but sometimes mastocytosis, actually the level can be low and can look much lower than what the allergy would be at that time. So you have to be
IgE per specific food or the
both,
overall body?
both.
We haven't even gotten food. We haven't gone to an allergist specifically to get food allergy tested because we're just all the reactions that he's having, we're treating like he could have an anaphylactic because he's had anaphylaxis. So it's trusting something that could be a false negative or even something that.
And they did tell us that because my son has reacted severely, and we almost lost him on his first birthday. We've only done RAS testing because they think that he's too sensitive to take him off the antihistamines to do skin prick testing, but then they told us the flip side is that the RAS testing could be inaccurate. So I mean, we have a good idea, and obviously we know one main one because he almost died from it. But we know pretty much the high ones on the RAS, they've said don't even touch, stay away from, but it's the low ones that they said just what you did, that these are showing up on a RAS test that they may not be as allergic, but we have no idea how he's going to react because we don't know if the masto is going to play into it. And again, like I said, I'm kind of kerfuffled because this week we just had an experience with that where now they're not even sure, the doctors aren't, and the allergist is who we went to go see, as if Monday was, because it was actually just residue from something that my mom crumpled up blue cheese, touched a cucumber, he ate it, went into anaphylaxis, dealt with that. 24 hours later, he was simply cuddling me, hadn't eaten anything, but we didn't think he'd come in contact with anything, and went into, we had to call 911 because it was worse than the day before. And they said that is probably from the masto versus an allergy because he actually hadn't eaten anything. But again, they have no idea.
Can't it also be a rebound reaction within those 48 hours?
They said that it could have been biphasic anaphylaxis.
It's very late though. However, I have patients where I hear the same thing, that there is a late biphasic reaction. Really not much described in the literature. So really, that's a field that needs a lot of work, and that's something.
So have you seen a lot of cases of kids that have severe multiple food allergies and mastocytosis?
I cannot tell you a lot of cases, but recently I have seen cases, and so that's something really that is, very challenging, and you know that. And that's something that
our allergist is phenomenal, but he's never seen the two together. Everybody we've seen, no one has seen his, like we keep hearing that my son's a guinea pig, which is fine to a certain degree, but as a parent you're like, what do we do now? Who does know anything about this, or where? That's why I'm here.
Yeah. So I think that's something that really information that we have to put together.
But what you're saying though is that the kids that do have both together, the masto does magnify the allergic
Absolutely,
reactions.
it does. And I have also heard about delayed reactions where you actually have another reaction the next day. It shouldn't really, there's only certain things that you can do, right? You shouldn't be walking around scared.
He said that they've upped his meds. This all just happened this week. Upped his meds. Obviously, we always carry 2 EpiPens with him, but he also gave us an oral steroid to try and again, that's something that he said is very iffy. He's not quite sure if he wants us following that route or doing it all the time. But again, we don't want a life and death situation he said the side effects from taking the prednisone versus not taking it and losing him.
But you have 2 EpiPens, is that right?
We have 2. We actually have 3, but we
you always have 2 with you, and you know how to
us.
use it and all this.
And they've upped his meds. We have the whole emergency protocol, but
okay.
This is the first time we've experienced the back-to-back one, and
okay.
Yeah.
Maybe you can tell me later a little more about it, but yeah, okay.
Okay.
So.
Yeah.
Maybe last question.
Yeah, one last.
I got a question, and it has to do with mastocytosis, but it doesn't. What is the medical community? It seems like there's a lot of medical ignorance. I'm in the Army, so I've been all over the country. We were in Tennessee, we were in Georgia, now we're in Massachusetts. And like, if you go down to the Southeast, like, you're almost shunned if you even mention mastocytosis or anything. And I'm wondering, what are the medical communities doing to like educate other medical personnel?
I mean, TMS, like I said, that we're going to.
Well, besides the society.
Right, and
like, what is it, like, allergy, dermatology?
Right.
What is
Because they very much think it's all in our head. Like, I can't tell you how many doctors said he's just having a panic attack. That's all it is.
The problem with the rare disease is that that's what you see in a lot of other rare diseases. Where, what people don't see very often, what doctors don't see very often, they don't believe in. That's just something. But I think that the society has done quite a lot.
I worked at a couple of the pediatric ones. We now go to, I think, 5. There's a pediatric one, an allergy immunology. We just started doing an emergency room, and then there's another one. But we have a TMS booth. There's thousands of doctors. I think the smallest one is at least, 2,000 or 1,500, 2,000. And they're interested. We have a display which is really graphic of a child, which kind of draws their attention in. I think it's really graphic, but it gets them in there. And we spread the word out enormously. I feel great after I leave those because so many doctors came by, and sometimes we'll just, if they just have any interest at all, we'll kind of grab them, and they may have walked away, and we pass out a lot of information. We get their contact.
From speaking with the society with Lisa, that they've split the research committee into research and education, and the primary mission for that committee of the society is to start promoting information again among more like primary care doctors. So maybe doing that sort of activity, getting other publications out into just the flyers that doctors go through on the way to work, basically.
Kids as well, because I know
yeah,
it's hard sometimes because I've been told it's like an adult thing where they don't really look for it in kids.
Right. Well, that was my interest in getting involved in this, actually, is because I trained as a pediatrician, first, and then as a dermatologist, and I didn't even really know very much about this until I started seeing more kids with it. So it's one of those things you have to kind of grassroots level, I think, educate people, but there is effort there, and I think having even the website available or some of these pamphlets now to show those people that tell you you're,
Yeah, like the reality is we have.
Yeah.
And, like, our doctor here would fax them information, and they would say, "I'm a doctor, I know what I'm doing," and they've thrown it in the trash.
Well,
they
then.
refuse to triage him.
We got a nurse here in Brookline. Like, Brookline's a business community, and like the nurse in Brookline calls our doctors, and like she sent an email to Dr. Costello's almost saying that we were liars.
That we were making up the story. I'm like, no, this is really wrong. Like, my son gets hot and he's going to stop breathing, but they really think it's just in our heads.
Yeah. Again, I can really,
The different practitioner.
I think so too. I agree.
You have to have a trust level. Yeah.
Is this a disorder that you're seeing more frequently, or is it just something that is coming more to light because more awareness?
Yeah, and then food allergies we see more frequently, right? So then the combination of it we will see more definitively.
And the more research I do, whatever. I mean, there's so many things and so much research going on about is it environmental factors, whatever. But when you said that about starting to see the case, I wonder if there is a correlation or why are all of a sudden.
I don't know if you can comment on that in terms of the incidence, whether you think the incidence is actually increasing.
I think it is increasing.
Yeah.
Obviously, we have better awareness of it, even though we're lagging way behind. But I've always been fascinated, obviously, because of the research I've been doing, about all these cases that are not necessarily, UP, and you don't know what to do with them because they present And it took a very long time, even for adults, to come up with the definition of mast cell activation syndrome. So at least there's something there that you can tell some colleagues, well, there is a definition. For the children, they don't quite even fit that definition. So what do we do with them?
And with no diagnostic criteria. Like, I mean,
Right.
I actually contacted Dr. Metcalf at NIH because I said, you proposed this diagnostic criteria. Can you please throw me a bone? Like, I mean, he doesn't fit into anything, and his tryptase was low. So we don't have, and I don't know if I want to put him through a bone marrow biopsy because he's sensitive to everything. He could go into anaphylaxis. I don't want to put him through that. So we're treating it like that's what it is.
Actually, there is a site, not for children, allergic to everything.
That's
seriously
exactly what he.
I mean, there
that's
are
how he
patients
lives. Yeah.
that are like allergic in quotation because
Right,
they just respond to everything.
Yep.
And they of course they don't qualify in any of these groups.
Yeah, because he presents like food allergies, like multiple chemical sensitivities, like GI problems. Like this is the only place that he fit.
Anecdotally, I felt part of why I got involved with this too is for a time there I felt like I was seeing a child with some form of a mast cell skin disorder. And during my training, it wasn't happening that often. And so I thought, is it something to do with New Mexico? Like I've just moved here. Is it that I'm seeing it more? And then of course months go by and I don't see a kid with anything. But I just have the feeling that the incidence is increasing. We know that the allergic diseases are, asthma, eczema, atopy, etc. So perhaps there's some kind of environmental impact there as well. So we just don't know.
The holistic practitioners that we've seen put multiples of them before we knew that he had mastocytosis or had a feeling, were telling us that his liver's toxic, that his body's toxic because he's taking on whatever's in my body when he's born. So, I know, people throw around in the woo-woo, acupuncture and all that stuff. That's how we've helped him to stabilize. But they're saying that it's toxicity. They're saying that their cells are getting so overtaxed, overloaded that they're not able to react to things that are...
There are some colleagues, mainstream colleagues, that do actually attest, which is fairly well known among us, that at some point it might be worth doing in some children. You know that all the mast cells are in the tissues, but in the blood we have circulating something which is a cousin of a mast cell called the basophil. And until recently we didn't know what the hell the basophil was all about, and we still don't actually. But they can actually remove blood and they look to see how well activated the basophils are, and they found that they also participate in some of these reactions, even though not through tryptase or other means. So there's a flood of publications recently rekindling interest in the basophil, and I'm kind of left wondering whether the basophil in some such children do play a role, and we just haven't quite explored it yet. But usually these are like research labs like Dr. Metcalf's or some others. But that's something that could potentially be done in a child that is absolutely responsive to everything. And maybe the mast cells are not even that many, and tryptase is low. Maybe one should be looking at the basophils, even though until now we didn't know what they do. I'm throwing a bone basically. I don't know what else.
I just want to say here, thank you everybody for participating. It's really great to hear the different stories. And I can tell you, the fact you can see there's a lot of questions that we really cannot give you a very good answer to, and that's that's one of the reasons that we're sitting here too. And there's a lot of things that we have to put forward and try to make better classifications, try to treat better, and particularly in kids, I think there's a lot of work to do for us. So all these questions really they motivate us to go back and look at how we can make it better. So yeah, thanks.
Thank all the doctors very much. Thank you.